It's really challenging for patients to manage pain, especially with, pediatric populations. Pain management is really difficult to get access to and to be taken seriously in children. So a lot of young people with EDS deal with constant chronic pain. I mean, some patients say they can't remember the last time they weren't in pain. It's been years.
This is the Innovatively Speaking podcast brought to you by the Medical University of South Carolina. It's the place where we dive into the origins of the next big things, the who, the why, and the how of ideas that are changing what's possible here at the Medical University of South Carolina, and in some cases all across the world. I'm Kevin Smith here in the MUSC podcast studio with my co-host, Dr. Jessie Goodwin. Good morning, Dr. Jessie.
Good morning, Kevin.
Jessie, you are the Chief Innovation Officer here at MUSC. Let's talk a little bit about today's guests.
I'm really excited about today's guests because I think that the impact of what they're working on could be profound and serve a huge number of patients sort of internationally.
The guests for today are Dr. Chip Norris, who's professor of regenerative medicine and cell biology. And we're also going to be talking with Dr. Courtney Gensimer, who is a postdoctoral scholar in the Norris Lab. Jessie, tell me how you became aware of Dr. Norris and Dr. Gensimer and their work in this area of Ehlers-Danlos syndrome.
So I've actually known Chip for several years. So I've been at MUSC for 10 years, and I think I met Chip pretty early on in that time. So we go back pretty close to a decade. And I think I originally met him when he was working on his other projects as part of his mitral valve prolapse studies within his lab. And then more recently, it came to my attention that he had made this really exciting discovery. And so I had reached out to Chip to have him come in and tell me more.
All right, well, let's dive in. Dr. Norris, Dr. Gensimer, welcome to the MUSC podcast studio. Let's start by defining Ehlers-Danlos syndrome and how you guys began doing this research.
Yeah, thanks for having us. So Ehlers-Danlos syndrome is really a group of connective tissue disorders. There are 13 recognized subtypes, and they all really cause a constellation of symptoms affecting the whole body. They include things like joint hypermobility, and that can lead to joint dislocations, tendon and ligament issues. They can also have cardiovascular manifestations, skin issues, gastrointestinal problems. But our work is really focused on the hypermobile subtype of EDS, and the hypermobile subtype is actually the most common subtype of EDS, but has really not had a known genetic marker since it's been defined as a condition. So our work has really been focused on trying to understand that.
And let's talk about maybe the how widespread is this syndrome. I honestly, before this podcast, I hadn't really heard of it much.
Yeah, it's well, first of all, it's great to be here. And so Ehlers-Danlos is it's known as the most common disease you've never heard of. And so there's probably a reason why you hadn't heard of it. We're trying to change that. The prevalence of the disease is really, there aren't that many great studies out there showing the exact numbers. There's a study really that we're basing our numbers on, which is that showed it to be about 1 in 500 people. And if you talk to physicians who see these patients, they'll say it's more common than that. So I think we're going with the 1 in 300 to 1 in 500 number somewhere in there. So it's Ehlers-Danlos syndrome. Certainly the other subtypes are viewed as exceedingly rare or rare diseases. But this subtype seems to be far, far more common.
Well, there was a connection between you guys on this particular subject, correct?
Yeah.
Can you talk a little bit about that?
Yeah, absolutely. So I actually have hypermobile Ehlers-Danlos syndrome myself, and I really wasn't diagnosed until college, which is a fairly common story, but I had symptoms my whole life. And part of my experience struggling with my health and, not getting diagnosed and things like that really inspired me to want to pursue a career in research or medicine, and led me to applying to MUSC. But once I got in, I really wasn't exactly sure what I wanted to do. I didn't, plan on studying Ehlers-Danlos because no one studies it, and so that wasn't really an option. But I met Dr. Norris on the first day of grad school at orientation. He spoke to all the new students and just said, I've been here for a long time. I even did my PhD here, and I'm happy to help students if you ever feel lost or need help sort of navigating the PhD process. And he was the first friendly face I saw. I had no idea what he studied, but I reached out and I said, can we set up a time to talk? And I think like 2 days later, I met with him. And he just started introducing me to his research on mitral valve prolapse and asked me if I knew what it was. And I said, yeah, because mitral valve prolapse occurs in Ehlers-Danlos syndrome and people in my family have it. And so he asked me what type of EDS I had, what my gene mutation was. And I told him that the hypermobile type didn't have a known gene. And I think he actually didn't believe me at first. He was like, oh, no, we know the genes for the Ehlers-Danlos syndromes. And I was like, not this type. And the conversation quickly kind of turned into, do you want to try to find it? On my first meeting with him ever.
Wow.
So I obviously chose to rotate in the lab, and that rotation turned into staying in the lab, and now that rotation turned into a postdoc in the lab. So that sort of chance meeting and him giving that opportunity to research something I'm passionate about changed my entire sort of trajectory of my PhD and my career.
Yeah, I think it was certainly not something that I had ever anticipated working on. It was always a slide in my presentations that patients with Ehlers-Danlos had higher incidence of mitral valve prolapse, and that was it. And she was telling me about the disease. I'm like, well, why isn't? It seems like it's so common and so debilitating. How is nobody studying this? And so I, in order to pivot or build one's research program in a lab, you have to do some sort of homework and try to understand the disease a little bit more. And when she told me that there wasn't a diagnostic tool or a genetic marker for it, I looked into that, make sure that she's a young student, so making sure she's right about that, and the prevalence and the burden, like what is the real need for this patient population? Is there a real need? And so from that we started working on it. She started working on it. She was when I said, well, do you want to find the gene find a gene for EDS, for HEDS? She said, we can do that, or you can do that. And I said, no, but you can. I'm not gonna. It's like your project now, or hopefully it was going to be her project.
I was sitting there, a brand new PhD student, like finding a gene. I was like, I was on the wait list. I didn't even get in here right away. So, I was like, oh, is this guy crazy, or is this the coolest opportunity
maybe
ever?
A little bit of both. Yeah. But I think as being a scientist and being in charge of a lab, you should have flexibility to be creative and open your mind and be innovative and try to, get out of the box a little bit and explore new things. We have the ability to do that, and we should.
Yeah. So I think that's actually a great segue to the question that I always like to start with, because I like to talk about innovation as a creative solution to a pain point, because I think that that's really helpful for sort of setting the context for why we do what we do around here. And so what are the types of symptoms that EDS patients struggle with?
Yeah, so I always like to talk about this to emphasize that it really is a spectrum, and every patient is going to be totally different in how they present. But typically the main complaints are a lot of musculoskeletal issues. So it's not uncommon for patients to have multiple orthopedic surgeries, spinal surgeries, need to use braces on their joints or mobility aids, things like that, to kind of be able to even just walk around and get through life. Or even in some cases, patients might not even be able to walk. And then there are a kind of constellation of other symptoms that can be present or absent depending on the patient. Sometimes that's gastrointestinal issues. So patients may have gastroparesis or delayed emptying of their stomach. They might have irritable bowel syndrome or mast cell activation syndrome that affects their GI tract. So for those patients, sometimes they need constant medication. They might need feeding tubes. They might struggle to eat anything orally, depending on how they present. And then a lot of cardiovascular manifestations. So a lot of patients have POTS, which is postural orthostatic tachycardia syndrome. It's been talked about a lot with long COVID recently, but POTS can cause patients to have issues with passing out, feeling lightheaded, struggling to go from sitting to standing, a lot of fatigue. There's also some neurological manifestations, so a lot of headaches. Patients can have Chiari malformation or craniocervical instability, which is what Dr. Patel here at MUSC sees a lot of patients for. But I would say the main things are really a lot of complaints of chronic pain, a lot of joint issues, a lot of fatigue, and then a combination of comorbidities depending on the patient.
And these aren't like, the pain isn't just like sore muscles and joints, right? I mean, it's real pain.
Yeah, it's really challenging for patients to manage pain, especially with, pediatric populations. Pain management is really difficult to get access to and to be taken seriously in children. So a lot of young people with EDS deal with constant chronic pain. I mean, some patients say they can't remember the last time they weren't in pain. It's been years.
That is absolutely crazy
And
to think about.
Bruising in the kids is a big thing because, kids who may have not necessarily had a diagnosis already, but they're in a family that has EDS. That if they go to the ER and a physician sees that the kid's got bruising all over just from running into a table, their vascular beds and their capillary beds are very leaky, and so Courtney has these massive
I
bruises
bumped into something in lab and
just from it's not like a big bump, and so it's really tragic because they'll have social workers then come in and take kids away.
One of the things as I was doing my own sort of basic research on this in preparation for recording this episode, that I thought was really interesting was that, particularly with the hypermobile type, that a lot of the patients told stories of this being seen as something that they should sort of utilize in their use. So they're put into gymnastics and sports that require a lot of flexibility. So their parents actually see this as an advantage and want to encourage it and start putting them into activities that would seemingly, go along with being hypermobile, and it just ultimately causes progressive damage. And to me, it was a little shocking because I, know as a parent myself that these are the types of things that you look for in your kids, like how can you promote their strengths, and how crushing it would be as a parent to figure out later on that you may have missed something and been causing harm.
I think my parents kind of went through that feeling later on, after I was diagnosed. It was right away like, oh, I'm sorry we pushed you so hard in sports and things like that. I remember, having an injury to my shoulder, having surgery, and then being praised in physical therapy 2 weeks later when my range of motion was back to normal already. And it was like, oh, you're recovering great. And I was like, it doesn't feel great. They're like, yeah, but your range of motion, it's so good. And so sort of even the readouts for progress after an injury or surgery might look different in EDS, where, if you have a shoulder that's dislocating and then you have great range of motion after, that might not be a great sign.
This is maybe a good segue to talk about the challenge of not having a genetic variant, a known genetic variant that you can test for. And so maybe you guys can comment a little bit on what that would mean to this patient population to be able to diagnose it early on.
So right now for hypermobile EDS, the way you really get diagnosed is through your physician going through a set of clinical diagnostic criteria. There's essentially a checklist that looks at joint hypermobility. So can you do these specific things that show that your joints are hypermobile, that we can kind of measure that? And then looking at more systemic manifestations. So the things I talked about, like mitral valve prolapse and some other things, is the skin stretchy? Does the patient have abnormal scarring? And you sort of just check through these boxes, and then at the end you say, okay, did we meet enough things to call this a diagnosis? The unfortunate part is that unless you have a physician who's super knowledgeable and is familiar with it, they will probably never even pull out this checklist. They might not even know that hypermobile EDS doesn't have a genetic marker, so they might think that, you don't have it because you didn't have a gene come up on a panel, things like that. So it can take a really long time, and, the issue is that patients see doctors in every specialty, right? So you see your shoulder orthopedic for a shoulder issue, and you see your GI doctor for something else, and you see your dentist for something else, and they're not talking to each other to say, why does this person have all of these problems, right? Is it part of something bigger? And to finally find out can be really validating, I think, because you're like, okay, I don't have 23 things wrong with me. I mean, you do, but they're all caused by one common underlying cause. So it can be really, really validating for patients to finally receive a diagnosis. And I think going forward with our genetics, it's even more validating to be able to have a solid, definitive test. And I'll let Chip talk about that a little bit.
Yeah, I think it's what the patients really want is, I'd say the vast majority of physicians are dismissive, especially, we in our registry, we see that a large number of these patients are teenage girls, and the physicians just say, "Oh, you're having growing pains," and it's like, no, but I have, and some of these girls have already had 4, 5, 6 surgeries by the time that they're 20 years old. And they still get dismissed. So, having a diagnostic tool, having a genetic marker is tangible evidence that they shouldn't be dismissed, and that this is truly a disease that needs to be taken seriously. And so, it also provides support for families. If you're a mom, and I'm just saying moms and girls because 90% of the patient population with EDS is female.
Really? 90%?
90%. And that's from previous studies and from our study, which is probably the largest. It is the largest registry right now. 91% are females. And the fact that the genetics tracks through families, if you have a child, you are going to want to know if they have this disease. It's sort of like having a BRCA1 mutation. You want to know. Having a diagnostic tool, having a genetic marker, provides an opportunity for families to be screened and know that when their child is growing that, hey, maybe they shouldn't be in gymnastics. Maybe they shouldn't be stretching out their ligaments to the point where they're never going to come back. It also gives us an inroads to, if we have a genetic marker or a genetic cause of the disease, it gives us the ability in the lab to make models and try to understand what's really causing the disease, and is there anything that we can do for those patients who have a lot of problems down the road. So, it gives us an opportunity to make animal models and understand that process. So it's really for us, it's the starting point of the study is developing these markers.
So on sort of your journey of innovation, we talked a little bit about your pain points at the beginning. So can you guys talk now about your aha moment as you're working towards sort of where we're going with this next? We talked a little bit about this. So can you guys describe your aha moment where you thought you found the marker?
So there's going to be multiple markers. There's going to be multiple genes. Right. So when we did this, we had a large family. People had done genetics on Ehlers-Danlos before, on this subtype of Ehlers-Danlos, and it hadn't been revealing. And our approach was to try to find a very large family, and you have a bit more genetic power with larger families. It's because you can watch it track through the family and be able to have an easier time finding what's tracking. So we had a large family, had 9 affecteds in the family through 4 generations. And so that was going to provide a good starting point. And so the approach was fairly simple. We just did whole exome sequencing on the 2 most distant related individuals who were affected, and got the sequence back. And then we had Joe Delaney here at MUSC, who's a cancer geneticist, do the analysis of the whole exomes. And he was the one who actually said that he's never had an aha moment in genetics, but this was one, because he said, look, you've got, 9 variants that are rare, shared between affecteds and potentially damaging. But there's really one that stands out above all the others. And so, we sequenced that one throughout the entire family, and that was the one that was tracking perfectly through the family. And so, and biologically, it made sense. And so it was like, oh, wow, and it wasn't, all the other types of EDS they're all related to collagen genes or collagen-related genes. And so people are thinking that this is going to be a similar thing that's related to collagen, or maybe it's a collagen gene. So it's what we found was not a collagen gene, but it can be related to collagen biology in some way.
So I feel like in the field of science, so many of us wait, our whole careers to have something where we find that one result that can be really life-altering. And so, Courtney, how did it feel to find it so early in your academic career?
Yeah, it was crazy, and I think it was kind of funny because I think when it happened, Chip was really excited, and I was like kind of excited, and he was like, "Wait, why aren't you excited?" And I was like, "I don't know, like are we sure? Like, what if we're wrong?" And I had all these like fears because I just felt too good to be true. Like I was like, this can't be right. This can't be right. And then I think it hit me like a little later than it hit him that, this is something. And I think maybe I had my guard up a little bit because, I'm a patient, right? So I didn't want to like be over the moon excited right away. Because I think for me, it wouldn't just be a scientific disappointment, but it would be like a personal disappointment. But now I think all the time, I'm like, is this really my life? Like, am I really doing this? It's sort of like I didn't ever plan for my career to go this way, but it's now I couldn't imagine doing anything else. I couldn't like possibly work on anything else, I don't think.
And I will say that, when we're still saying that the gene is a candidate gene, and we're saying that until it's published, and then we'll say it's a gene. But I think it's important to sort of, the data are, to us, very convincing, but it needs to be reviewed by, a scientific journal, which will be in the next few months. So,
Well, take it down to a lay level, if you will. Say young Courtney got this information. Tell me what that would do for you moving forward, and maybe what kind of benefits.
Yeah, absolutely. So I think that, when we talk about diagnosis, although there's not a treatment, early diagnosis can make a big difference. And this has been shown and published that patients who are diagnosed earlier have better outcomes, less comorbidities, less surgeries, less complications down the road. So, if I had known in childhood and I didn't do gymnastics and I didn't run competitively and play college lacrosse in the beginning of college, all of those things are part of the reason why I've had so many issues today. A lot of my injuries are a consequence of all of the extra stress I put on my body. So, my parents could have steered me towards, more creative activities like art or music rather than running basically 24/7. And there's a lot of other things too that could have made a difference in terms of my care. So if you're having a surgery or you're having even an emergency, say you're in a car accident and you're taken to the hospital, having EDS on your chart when a physician is knowledgeable can change the care that you receive. So even simple things like you're having a surgery and they know that EDS patients don't heal as well from surgical incisions. They're going to do extra things to be careful on how they close the incision so that patients won't have their wound reopen, won't be at increased risk of infection, things like that. One time I was unfortunately in a car accident and I was brought to MUSC and I had EDS on my chart. And so the first thing that the physicians here did was check my aorta and make sure that, everything was okay that could have been at risk of tissue damage during the accident. So there are really important benefits to having an earlier diagnosis in lifestyle choices and in how physicians might approach you with a health issue.
And for us in our registry, we're only IRB approved to accept patients who have a clinical diagnosis of HEDS. So we can't take those patients. So the point is that physicians look, if they have the disease, give them that on their chart so we can enroll them.
And I think having a diagnosis, there's a lot of online community for EDS. And so having a diagnosis makes people, join those communities, and then they might learn about a doctor who's really knowledgeable so they can try and see that doctor. And it just opens all these doors of possibilities to improve their care. I mean, for most patients with EDS, they're going to be in physical therapy most of their life. Just having a diagnosis can help with getting a physical therapy appointment, going to regular physical therapy, trying to prevent more issues down the road. I think that's a big part of EDS is really more prevention. So if you can start physical therapy with a child, teach them how to protect their joints, things like that, you can try to prevent more of the long-term issues.
You guys mentioned a few times the registry that you're creating, but can you describe that in a little bit more detail?
Sure. When we started this, we needed to get IRB approval, and I thought, okay, this is not going to be a big deal. We'll get IRB approval. We'll develop this registry. And I remember talking to Dan Judge, who's a cardiologist here, who's expert in cardiovascular genetics, and he said, "Are you prepared for what's going to happen?" And I said, sure. There's going to be 50 people who register, and we're going to get some families and stuff. And he's like, "You might be surprised," because he's very familiar with HEDS and is one of the physicians who can diagnose it, and here at MUSC. And so we're not allowed to advertise our registries at MUSC. So somehow word got out. Not through any source of us, but and literally overnight it became the world's largest registry in 24 hours, with over 1,000 people in one night, one or 2 days, something like that. That was two Christmases ago, 2 Decembers ago, right? And so that was, that was a bit scary for me as an investigator. Like, what am I gonna do? How am I gonna manage this? Because, I'm a scientist. I don't run large registries. So we had to figure it out. And so we partnered with Sector here, and we have 6 or 7 clinical coordinators who are on and doing the registry for us, which is amazing. It's been incredible. We are continuing to enroll. We have over 4,000 now, and it really provides an amazing amount of information about the patients. And what's also really telling is that, whenever you have a registry that gets that much interest in that short of time, it tells you that the public is wanting that to happen. And it's just sort of, how it's spread throughout the country and across transatlantic, it is just amazing. I mean, we have people from all over Western Europe who want to enroll. We have people from Australia. Right now, we can only enroll people in the U.S., but it's very telling that these people want somebody to be working on it, and so the process is very simple. They do a pre-consent, and then we register them for an actual consent with one of the clinical coordinators. And once that's done and they're deemed eligible, then we ship them a saliva kit. And that's all they're donating is their spit. And that is where we begin with our genetics. And so that was really an incredibly scary time. I remember that day when my email just kept going off. And I'm like, I gotta go. I can't. I can't. I don't know what to do with these 1,000 patients. And then we figured it out. I mean, we were able to mobilize the team pretty quickly.
During our preliminary conversation before we got here to the podcast studio, one of the things that you said that stood out to me was you were having the patients work on this themselves, do the research themselves. I don't know if I'm using the right terminology, but it was fascinating to me that you're kind of equipping them to do some work. Can you talk about that a little bit?
Yeah, so I think this really sort of stemmed from me and being, a patient, but also being a scientist in the lab. And we started getting requests from, undergraduate students who wanted research experience, who wanted to go to med school or graduate school, and reaching out and saying, do you take undergrads? Do you take volunteer interns, things like that? So we decided to start an intern program in our lab. We wanted it to be a program that gave students with Hypermobile EDS themselves the opportunity to do research in the lab over the summer, provide them with housing, provide them with a stipend, and really make sure that they were given everything they needed to succeed, even with having, disabilities and a chronic illness in the lab. So we started this last summer for the first time, and we had 4 students last summer. This summer we have 5 students. They're from all over the country. They're in various stages in their education journey. So, some are undergraduate students. One of them is a postbac who's a little non-traditional and decided she wants to go to med school because of having EDS. We have a med student. And it's really been an awesome opportunity because I think when you have a condition that's been neglected clinically and in terms of research, the patients are really the expert on their own disease.
And extremely motivated, I would think, as well.
Yes, absolutely. And so I think, having their insight is so different from any paper that you can read. I mean, there's so many times where I say this is an EDS thing, and then I look in the literature and I don't find it anywhere. But, every physician who sees these patients knows that happens in EDS. So I think patients, they can really ask the right important clinical questions, but then because of their science background and because of the tools that we give them, they have the opportunity to try and answer those questions in the lab. So it's something we're going to continue to do, and I think that it makes the research really powerful, and I think it means a lot to patients to know that the scientists working on it, have their best interests and are part of the patient community.
When we listen to the patients, one of the things that we hear frequently is that physicians discount this disease. And so why? And how are we, or if you don't even care about the why, how are we going to change that? Because it needs to be changed. And so the way to change, how do you change perception about a disease? And so the way to do that, in our opinion, my opinion, is you really have to start with education. And these currently, right now, Ehlers-Danlos syndrome, the whole spectrum of Ehlers-Danlos syndrome, of which there are 13, 14 subtypes, gets one slide on a medical school lecture. It is one question on the step 1 boards, and the question is something like, lists a connective tissue disease, or is Ehlers-Danlos a connective tissue disease? It's woefully misperceived, and the education in clinical schools, healthcare settings is just absent, and so we need to change that at the very basic level, and starting with these interns. The goal is, over the next, we recently received funding for 3 more years of the intern program, fully funded through the Fullerton Foundation, which is amazing. We'll have 15 or 20 people in our lab who have gone through, and the goal is for them to all go into healthcare settings. Nursing, PT, medicine, science, psychiatry, doesn't like anything but staying focused on Ehlers-Danlos. And in doing so, they then will be educating the 200 or 250, med students that they teach. And so by doing that, then you can change the perception. We're working with Donna Kern at MUSC to try to change the medical school curriculum to be able to implement new lectures on Ehlers-Danlos, because it's going to be something that the physicians see. It's going to be something that every healthcare provider will see. And so they need to get educated. And in that way, what we're doing yes, it's great for these kids to come in and do some science around their disease, and they're very passionate about it. But they need to move that forward, and in doing so, then you have the opportunity of changing really how the disease is clinically viewed, and that's, as me as a PI, that's sort of one of my missions. Is hopefully that'll be part of my legacy.
It seems, well, a few thoughts I have. One, how incredibly empowering it is for the students that you have in their lab to not only have attention paid to this clinical issue that they're suffering from, but to be able to pay that attention themselves and sort of to arm them with the skills to be able to tackle it and advance the field long term. But also that you're working really at the heart of the conundrum, right? So the prevalence of this is much greater than I think most people realize. But I think as a society, we focus really probably rightfully on evidence-based medicine, but if it's a clinical diagnosis that's not really getting studied robustly, then there's a lack of evidence in peer-reviewed literature. And so to be able to take this student population that you're training and actually arm them and give them these opportunities to advance the literature field such that they can really sort of increase the amount of evidence in the field goes back to what I said at the beginning, how incredibly empowering that must be to them. Because I think if we can do that, to your point, Chip, then the education will come, right? So the more that you can put out there that's peer-reviewed, that is in the literature and scientifically accepted, the easier time we'll all have in terms of increasing that education aspect of it for these students. So,
you know, that if you just look at the economic burden of one patient with EDS, it's, and Courtney can tell you she's a patient, is about a $250,000 economic burden per year, every year of their life. So there's about 800,000, we estimate about 800,000 patients with EDS in the U.S. You multiply that by $250,000 a year, you're in the multi-billions of dollars, and over a 30-year period, it's $10 to $20 trillion. So the economic burden, if you get to these patients earlier, then they're going to have less comorbidities. The burden's going to be less, and their health and their quality of life is going to be much better.
Well, I think it's extremely exciting and obviously critically important. And I think you guys are really reflective of what it means to be at an academic medical center where we can really couple all of those pieces that as a whole make up your vision, right? So this really important foundational work on the basic science side that drives the field forward hand in hand with the clinical expertise that we happen to have here. And hopefully it's not too far off in the distant future to sort of see your vision realized where we can have an EDS institute at least scattered throughout the country, even if we can't get one in every state, but really would go a long way towards improving the lives for patients like Courtney who are dealing with this on a daily basis.
For any additional questions about our HEDS research and our registry, email edsregistry@musc.edu. You've been listening to the Innovatively Speaking podcast with the Medical University of South Carolina. If you enjoyed this episode and would like to support the show, leave a rating and review. To hear more innovative ideas and to share your own, subscribe to the show or visit us on our webpage, web.musc.edu/innovation. And remember, don't hesitate to innovate.